Hi, welcome back to UWorld's Next Gen NCLEX review. My name is Samantha and I am a nurse here at UWorld. We're happy to have you here today. Today we're going to be covering kind of a tricky subject. We're going to be focusing on acid-base imbalances and those ABGs, so covering everything from metabolic acidosis and alkalosis to respiratory acidosis and alkalosis, as well as those causes, clinical features, and our nursing interventions. So it is some difficult subject matter, but I know you guys are up to the challenge. So we're just going to take it nice and slow today. It might be a longer live, but any questions that you have in the meantime, go ahead and drop them in the chat and let Nurse Jackie know. She is moderating for us today and she's excited to hear from you all. So again, we're going to take it nice and slow and we're going to get through it together. Follow us at UWorld Nursing for more information on our lives. And a couple of housekeeping things before we get started. All of our lives live on demand, I believe now on all of our social channels afterwards. So if you missed something or you want to clarify something, check back in on our social channels and you can revisit these videos in the future. Let us know if you've already tested and passed your NCLEX so we can congratulate you, or if you have yet to test so we can wish you good luck. It's always so interesting to see where everyone is in their nursing journey. As always, drop those comments, questions, and answers in the chat. We will be finishing up with a special 3 NCLEX style questions today as opposed to the normal 2. So we have an extra question for you guys to test your knowledge. So go ahead and make sure you use that chat feature, say hi to Nurse Jackie, and let's go ahead and get started today. Alrighty, I see someone off the bat is testing on the 11th of this month. Good luck. 11 is my lucky number, so I have a good feeling for Shelly Ann. Okie doke, so let's lay some groundwork here. Acid-base imbalances. So something to remember is that acid-base imbalance is going to be a complication of a condition. It's never going to be a standalone diagnosis on its own. Acid-base imbalances are going to be in the background when something else is going on to cause it. So these imbalances are going to be focused on dysfunction in one of 2 areas. It's either going to be metabolic imbalance, which is based on the kidneys, or it's going to be a respiratory imbalance, which is based on lung problems or problems with breathing. So let's go over our normal lab values so we know where our normal levels are. That way we know how to spot a problem if a problem does arrive. So we're going to look at 3 main serum lab values. The first is the simplest, and that is just pH, which means potential of hydrogen. So it's going to tell us, is our blood in a normal range? Is it acidic or is it alkalotic? So what is a normal pH range? I'm going to put this question out to the chats. It's kind of an easy question, but let's get it started. Who knows what a normal pH range is? I'll give you a hint, it's in the 7s. But go ahead, drop that in the chat. Let me know what that normal pH range is. Let's get this chat going. I see Nia already answered. I see Shelly Ann had a correct answer. Way to go, you guys. Yep, you got it. So 7.35 to 7.45 is our normal pH range. Anything below that 7.35 would be on the acidosis side. Anything higher than that 7.45 would be on that alkalosis side. Okay, so next thing we're going to look at is carbon dioxide, or our CO2. So we've learned about CO2 a few times on these lives, and we know that CO2, carbon dioxide, makes us acidic or makes us have a low pH. So our normal CO2 range is just 35 to 45. And a great way to remember this is if you take that pH level, which is 7.35 to 7.45, and you drop those 7s, you get 35 to 45, which is an easy way to remember this. Now moving on to our last value to remember, that's going to be our HCO3, or our bicarb, our bicarbonate. So a normal bicarbonate range is going to be 21 to 28. High levels of bicarb are going to make us more alkaline or in a state of alkalosis. And you may hear this called bicarb. Bicarbonate is a base, which makes us more alkaline. Important to remember. So the last little bit, just to sum up what we learned before we get started, is acidosis is going to occur from either too much acid accumulating or losing too much bicarb or base. On the flip side, alkalosis is going to be from too much base or the loss of too much acid. So I know this can get kind of confusing, but by remembering these key principles, it's really going to help guide you through this lecture. So with that being said, we're going to move on to our metabolic side. So we're starting with our kidneys. We have a great acidosis scale that we're going to pull up. It's just a great visual. And a reminder here that any of these visuals that we put up, you're free to screenshot, take a picture of. I think whenever you're going through a difficult subject, it's always so helpful to have a visual reference there for you to help. Alrighty, so we're going to start with metabolic acidosis. So we know metabolic is going to refer to our kidneys. Our kidneys are impacted, and acidosis either means too much acid or a loss of too much bicarbonate or base. So reasons or causes for metabolic acid can either be from too much acid production, which simply can mean we're just making too much acid. We can see an increase in lactic acid for reference, and lactic acid circulation, which can result from poor perfusion or carbon monoxide poisoning. We can also see acidosis from the release of too many ketones, like in DKA, or diabetic ketoacidosis. Or it can simply be from intaking too much acid, and that can be from too much aspirin, which is acetyl salicylic acid. It also can occur, acidosis can occur from impaired excretion of acid. So we're not getting enough acid off and excreting it, like with kidney disease. Now, we just did a chronic kidney disease lecture, I think 2 weeks ago. So if you have more questions about the kidneys, go ahead and check back in with that. But remember, our kidneys decide what gets excreted through our urine and what we hang on to and put back into circulation in the blood. So if these kidneys aren't working right and they get backed up, we're going to have a buildup of this waste and the electrolytes in the blood, including these acidic elements, which can lead to the state of acidosis. And our last cause for metabolic acidosis is going to be from losing too much bicarb or losing too much base. And a way that we can see this in a clinical setting is actually through diarrhea. We're excreting too much bicarb through diarrhea or those frequent loose stools. Alrighty, now we're switching gears from metabolic acidosis into metabolic alkalosis. So we're going to switch to our alkalosis scale. So what are some causes of metabolic alkalosis? Now we're on the side where our pH is higher, we have too much base and not enough acid. So the same principles apply here as with metabolic acidosis. They're simply in reverse. So it's a inverse relationship. We know that metabolic, again, means the kidneys are impacted, and alkalosis means we have too much bicarb and not enough acid. So the reasons for too much bicarbonate, again, they can be as simple as too much ingestion of bicarb, like with antacids, like Tums. These are pretty much just pure bicarb tablets, so this can put us into a state of alkalosis. Or it can happen from large amounts of acid loss. So what are ways that we lose lots of acid? Well, with vomiting. Think of our stomach. When we're vomiting up that acidic stomach acid, we're losing that acid. And the same premise applies with suctioning. If we're suctioning too much, we're getting too much of that stomach acid out, we are losing too much acid, and we're going into a state of alkalosis. In the same vein, diuretic medications can also cause this. They cause us to excrete hydrogen, which we know hydrogen is acidic, and we know this is a driver for our pH. After all, pH means potential of hydrogen. So when we're losing hydrogen, our pH is getting higher, putting us into alkalosis. Alrighty, so I'm going to check the chat, see how you all are doing. And now we're going to move into our clinical features. I hope you all are sticking with me. I know this is a tricky subject. So let's move on to our acid-base table. And this is a great kind of home base for us on today's lecture. So our clinical features, what is a client with metabolic acidosis going to present like? So a couple key things. Let's think back to our causes of metabolic acidosis. DKA, or diabetic ketoacidosis, super common cause of metabolic acidosis. So clients may have small respirations, which is a classic sign of DKA. It's those really frequent shallow breaths they're taking. They may have signs of hyperkalemia as well, which we know that hyperkalemia can cause cardiac complications, specifically dysrhythmias like tall peak T waves. We just did a live on electrolyte imbalances specific to potassium, I think 3 or 4 weeks ago. So again, any questions on that, go ahead and check those out. And we also know in metabolic acidosis that diarrhea can be a cause of this because we're excreting too much base or bicarb. Now, switching gears to clinical features of metabolic alkalosis, here it's kind of the same lines, but instead of diarrhea with metabolic acidosis, it's the other end. It is vomiting. We see with vomiting, we're excreting too much of that hydrochloric acid, that stomach acid. It puts us into a state of metabolic alkalosis. And in general, our client is going to just not feel very well in a state of metabolic alkalosis, but it's very common to see them vomiting with this. Alrighty, so we know what they look like. Now, how does the body compensate? How does the body help us out when we find ourselves in one of these states? So with metabolic acidosis, remember we have a low pH and a low amount of bicarb. So in response, the kidneys aren't working completely up to the speed they should be. So our friend, the lungs, jump in to help out. The lungs are going to kick in to help out our kidneys. So what the lungs do in metabolic acidosis is that they increase their rate of breathing. So we're going to have an increased respiratory rate. So we can blow off that extra acidic CO2. So we have less acid putting us back up to a higher pH in a normal range. And again, when we blow off that CO2 by increasing our rate of breathing, our pH is going to rise and our bicarbonate is going to rise as well. Now, switching gears, metabolic alkalosis, again, this is going to be the opposite, so think everything in reverse. Here we have a high pH and a low amount of acid. So in response, the lungs, again, they kick in to help out our friend the kidneys, and the lungs are going to slow down or hypoventilate in order to hang on to that acidic CO2. So with metabolic alkalosis, we're going to see a decreased respiratory rate. So we hold on to that acidic CO2. This will help to lower our pH, hopefully into a normal range, and our bicarb will lower as well. All right, so I'm going to do a quick knowledge check, see how you guys are doing. I know this is tricky. So in metabolic acidosis, so that's key, metabolic acidosis, will our rate of breathing increase or decrease? Okay, so I'll say it again. In metabolic acidosis, is our rate of breathing going to increase or decrease? And I'll give you a few seconds. You guys are doing great today, per usual. Alrighty. So I see Alyssa answered, and Alyssa said increase. Well, Alyssa is correct. Way to go, you guys. We are going to increase our rate of breathing in metabolic acidosis to breathe off that acidic CO2 to increase our pH and hopefully bring us back into a normal range of 7.35 to 7.45. Alrighty. Great job with that one, guys. So now we know how the body compensates in metabolic acidosis and alkalosis, but what are our nursing interventions? What can we do as nurses? So the key thing to remember here is that whether it's metabolic acidosis or metabolic alkalosis, this is never the primary diagnosis, but rather a symptom of another condition. So what we need to do is treat the underlying cause, whether that's DKA or emesis, whatever's happening here. But there are also some other essential practices that we should know as nurses. So we always want to continue to monitor our ABGs so we know which direction this client is trending. We want to make sure we're giving lots of IV fluids, replacing electrolytes as needed. Now, for metabolic acidosis in particular, we're going to monitor those lab values, especially that lactic acid. Again, anything that makes us more acidic puts us into a higher state of metabolic acidosis. We know we see elevated lactic acid in our septic clients, so we really need to watch how this is trending. We're going to replace fluids and electrolytes as needed, and we're going to give certain medications. So we know that with a client in metabolic acidosis, a potential cause of this is diarrhea. So we may need to give an antidiarrheal like a Lamodal, since we know the client is going to have a loss of bicarb through that diarrhea and through that stool. And we may even give bicarb to the client. Now for metabolic alkalosis on the other side, it's the same principles here. We're going to treat the underlying condition that's causing this first, as well as replacing fluids and replacing electrolytes. In this case, we know that vomiting can lead to metabolic alkalosis. So we're going to give medications like an antiemetic to help control that vomiting and hopefully cease it. If this is caused by diuretics, we're going to stop the use of diuretics so our kidneys can start sending some of that hydrogen back into the blood as opposed to excreting it through our urine. And if this is caused by suctioning, we're going to make sure we avoid suctioning so we're not getting out any more of that stomach acid, making us more alkaline or more basic. Alrighty, great job with that, guys. So we're going to move on to our flow chart. Again, another great visual reference. And I'm just going to do a quick summary of the metabolic acidosis and alkalosis before we switch gears into our respiratory side and hit those lungs. So a refresher for you guys, metabolic acidosis, again, means low pH. This happens from too much acid and the loss of too much bicarb. Our kidneys first, it's metabolic, they try to compensate, but they end up calling for backup for our lungs. Our lungs in compensation will breathe faster or increase our rate of breathing to breathe off that CO2, which is acidic. And then when the pH returns to a normal level, we will be considered fully compensated, but we will end up with a lower CO2, a lower acid, because we blew it all off with that increased respiratory rate. So this actually puts us to a state called secondary respiratory alkalosis, and that is simply from compensation. Now, moving on to metabolic alkalosis, this means we have a high pH. We're above that 7.45 mark. This happens from a low amount of acid, low hydrogen, low CO2, and a high amount of bicarbonate. So our kidneys, again, they first try to compensate, but they're going to need to call for backup from our friend, the lungs. Our lungs are going to, in return, breathe slower to hold on and cling on to some of that CO2, which is acidic, to be able to increase our amount of acid, which will then lower our pH. When our pH returns to a normal level, we will be considered fully compensated, but we're going to have a higher CO2 because we've been retaining it to get us back into this normal pH range, and this puts us into a state called secondary respiratory acidosis, which again is just from all of the compensation. Alrighty, great job, you guys. Way to go. So we are now going to switch gears from metabolic into our respiratory section. So we are halfway there. Way to go, you guys. Let's go ahead and pull up our acid-base table, just kind of hit that home base again. Alrighty, so we're going to do a quick refresher on some respiratory concepts before we dive into respiratory acidosis versus respiratory alkalosis. So we're going to be talking a lot about respiratory drive next week in our COPD live lecture. So make sure if you have more questions about that, tune in next Tuesday at 12 p.m. Central Time for more information about COPD and the respiratory drive of the body. But just a quick refresher here, we'll go quick with this. We breathe in oxygen, I'm sure you all know that. The oxygen makes its way through our upper and our lower respiratory system, where gas exchange eventually happens in the alveoli of our lungs. So our blood offloads CO2, again, which is acidic, and picks up the oxygen at our alveoli. So this CO2 is really where some of this imbalance starts to happen, starts to take place. So in respiratory acidosis, when we're hypoventilating or breathing slowly, we have a buildup of that CO2 in the blood, making us more acidic and lowering our pH. On the flip side, in respiratory alkalosis, we're hyperventilating. We're breathing too fast. We're blowing off all of our CO2, which is acidic. We're doing this too quickly, and this causes us to lose the acid and raise our pH due to, again, a lack of acid, and this is the core of respiratory alkalosis. So quick summation here is that hypoventilating is going to happen in respiratory acidosis, so not breathing enough, and hyperventilating is going to happen in respiratory alkalosis, or breathing too frequently. Alrighty, so knowing that, let's apply it going forward. Alrighty, I see someone asked me to go a little slower, so I will slow down. So what are some causes of respiratory acidosis? So let's talk about, we're going to start with acidosis side. Let's just, we really need to tie all of the causes, and a great way to remember them is tying them into what are some causes of hypoventilation, or a decreased rate of breathing. So let's start with acute causes. First, our client could have an airway obstruction, like along the lines of choking or aspirating. This could lower our rate of breathing. We can also have chemical respiratory depression. So anything along the lines of opioid overdose, maybe acute alcohol intoxication. And another cause to note is that we can have respiratory muscle weakness. This may present from Guillain-Barré syndrome, which we know is that rapid ascending paralysis, or it could also come from a spinal cord injury. Remember that the part of our brain that controls our breathing is in our brainstem. So injury in the cervical spine area can impact our breathing and our respiratory drive significantly. Now, chronic causes, that's a tongue twister, are going to be obstructive pulmonary diseases, so COPD. Again, we have a live next week on COPD, so tune in for that. But in COPD, the clients here, their respiratory drive is going to be triggered by oxygen instead of by CO2. So their body becomes super accustomed to these rising levels of CO2, and that's going to blunt the body's respiratory response. Alrighty, now switching gears to the causes of respiratory alkalosis, we're going to move on here. So in alkalosis, respiratory alkalosis, we are breathing too fast. We are hyperventilating. And what are some causes here that can cause hyperventilation? So some of these are mental health related, things like panic attacks or an acute anxiety attack. We can also see pulmonary conditions like pneumonia, an asthma attack, a pulmonary embolism, or a PE, which causes that sense of anxiety. Clients may start to breathe too fast. All of these things are going to cause impaired gas exchange, either from obstruction in the airway or in the lungs. Other causes of hyperventilation that can lead to respiratory alkalosis include fever, high altitude, an improper ventilator setting on a client that's already receiving mechanical ventilation, all things that can cause hyperventilation that can lead to respiratory alkalosis over time. Alrighty, so clinical features. What are these clients going to present with? What are they going to look like in a clinical setting? So respiratory acidosis, we always start on our acid side. What are these clients going to look like? So beyond our decreased respirations from hypoventilation, these clients will eventually start to show neurological manifestations because of that high CO2 and that low oxygen or hypoxia. So think not enough oxygen to the brain. What can happen here? We can see confusion, lethargy, drowsiness, as well as headache. And if these symptoms go unchecked and there's no intervention, it can progress and with later signs of things like seizure and eventually coma. So again, early intervention is paramount here. Moving on to respiratory alkalosis, what are some of our clinical features? So again, respiratory alkalosis, we're going to have a low amount of CO2 and a fast respiratory rate. So we're hyperventilating here. We can see some manifestations like lightheadedness, dizziness, confusion, and tachycardia, or that increased heart rate. And due to the other process happening in the background that's causing this respiratory alkalosis, we can see things like hypocalcemia or not enough serum calcium. And common clinical findings associated with this would include tetany as well as numbness and tingling, especially around the mouth area. Alrighty, so the same as with respiratory acidosis and respiratory alkalosis, we're going to have those severe late findings if this goes untreated. And those can be seizure and even potentially coma. So again, so important to know how to identify these findings and intervene early to prevent it progressing to seizure or unfortunately coma. Alrighty, so now let's look at compensation. How is the body going to respond? Alrighty, so let's start with the respiratory system again. So just how our lungs compensated for our kidneys in metabolic acidosis and alkalosis, the reverse is true in the respiratory system. So our kidneys are now going to step in, they're going to compensate and help out their friend the lungs when we have respiratory acidosis and respiratory alkalosis. Alrighty, so in respiratory acidosis, we know we are too acidic from the buildup of that CO2. So our kidneys, our good friend the kidneys, jump in by secreting hydrogen in the urine, which we know hydrogen is an acid, so it's going to help raise our pH, which is what we want here. Our kidneys are also going to reabsorb or send back some of that bicarb or that base back into our bloodstream circulation. This is going to, it's a base, so it helps to raise our pH, making us more alkaline and taking us out of an acidotic state. Now in respiratory alkalosis, same premise, just in reverse. We know in respiratory alkalosis, we have low levels of CO2 and low levels of acid, so we need to increase the amount of acid in our system to help to lower our pH and take us out of alkalosis. So our kidneys are going to reabsorb hydrogen, to send hydrogen back into the blood, and they're going to reduce the amount of bicarb that we are producing. This is going to help bring our pH back down to normal. Alrighty, so a quick knowledge check. Let's take the pulse, you guys. So will hydrogen concentration increase or decrease in respiratory alkalosis? So I'll say it again. Will hydrogen concentration increase or decrease in response to respiratory alkalosis? Alrighty, let's see what you all are thinking. All I'm looking for is increase or decrease as an answer, but this is a tricky one. That being said, y'all have gotten all of these correct so far. All right, I see Ashley saying increase question mark. I see Hannah say increase. Well, no need for the question mark because you were correct. It does indeed increase. Remember that hydrogen is acidic, so when we increase it, it helps to make us more acidic, taking us out of respiratory alkalosis because it's making us more acidic. Alrighty, so our nursing interventions, we just covered how the body kicks in to compensate. Now, what can we do as nurses to help these clients? Remember again that these respiratory acidosis or alkalosis, it's never the primary diagnosis, but rather a symptom of another underlying condition. So obviously it's important to treat that underlying cause, but there are some things that we of course can do as nurses. So monitor those ABGs closely, make sure we're trending in the right direction. We can give IV fluids, we can replace our electrolytes. Now for respiratory acidosis specifically, we're going to work on improving our airway, improving our breathing, because these clients in respiratory acidosis are hypoventilating. They are not breathing fast enough. So things that we can do to help them with this would be raise the head of the bed. If they have any secretions, we would help to suction these out to clear that airway. We would apply some supplemental oxygen, maybe a nasal cannula, maybe a higher level, and give medications that treat the condition. So if this hypoventilation has been caused by an opioid overdose, we may need to give Narcan to reverse that. And in the case that we're not able to intervene and see good progress, we need to be ready to intubate this client if necessary. And in respiratory alkalosis, on the flip side, we need to work to make sure we calm this client and decrease that rate of breathing because they're hyperventilating or breathing too quickly. So we may need to give supplemental oxygen, which is the same as in the past one, and give medications that help this client. So if they're hyperventilating from a panic attack or an anxiety attack, something like a benzodiazepine would be helpful to calm their anxiety, hopefully slow their rate of breathing. We need to provide and maintain a calm atmosphere, encourage slow and deep breathing to help decrease this rate of hyperventilation. Alrighty, so we're gonna head back to that flow chart and we're gonna do a quick refresher for you guys just on respiratory acidosis versus alkalosis before we move on to our Rome trick and how to distinguish between all four of these things. So with respiratory acidosis, remember acidosis, we have a low pH. This typically happens from hypoventilating or holding on to too much of that CO2 because we're not breathing enough of it off. So our kidneys jump in and they compensate for our lungs. But an important thing to remember is that our kidneys compensate slowly. So it's a very slow and delayed response. Our kidneys are going to increase the elimination of hydrogen to help raise the pH in our blood, make us more alkaline. They're also going to retain that bicarb to help raise our pH as well. But again, it happens slowly. The kidneys work slowly. So we may need to offer additional support, like airway and breathing support in the meantime, while it takes a while for these kidneys to kick in. We also may need to push sodium bicarb in the meantime to help to increase their pH level and take them out of respiratory acidosis. On the flip side, respiratory alkalosis means high pH. We are alkaline. This happens from hyperventilating, breathing off too much of that CO2, leading to not enough acid. So again, our kidneys compensate for our lungs. They jump in and help out our friend the lungs, but they do this slowly. Kidney compensation is delayed. It's a slow process. But what they will do is kidneys are going to hold on to hydrogen in the urine, which is an acid, and they're going to lower the bicarb production too, which is going to help give us less base and increase our acid, and these two things hand in hand will help take us out of alkalosis. So again, these things happen slow. The kidneys work slowly, so we need to make sure that as nurses we act fast, do our interventions in the meantime. In the case that they are hyperventilating, we need to calm them, encourage them to breathe slower, and if they are on a ventilator and that's what's causing the respiratory alkalosis, we may need to decrease these ventilator settings so they're not breathing as quickly. Alrighty, so that sums up respiratory acidosis and alkalosis. Now we're going to move on to how to differentiate between all four of these things using lab values. Kind of the tricky part, the most tricky parts, taking everything that we've learned today and combining it. So we're going to switch to our Rome image. Rome, just like the city in Italy. Alrighty, is anyone joining us from Rome? I don't know if there's a chance of that, but how cool would that be? Or anyone joining us from Italy in general. But Rome is spelled exactly like the city. And what it stands for is respiratory opposite, metabolic equal. So what does this mean? There's really three components to doing these acid-base imbalance questions that we're going to have coming up next. First, we're going to figure out, is this alkalosis or is it acidosis? And this is the easiest part of the lecture. So what we do is simply use that 7.35 to 7.45 normal range. If it is underneath that 7.35, we know we're in a state of acidosis. If it's over that 7.45, we know we're in a state of alkalosis. So all we do is use that pH to determine whether it's acidosis or alkalosis. That's part one, and I know you guys already have that on lock. Alrighty, so part two is figuring out, well, is it respiratory or is it metabolic? And the way that we do this is using this Rome trick. So respiratory, our pH and our CO2 are going to move in opposite directions. This is an inverse relationship. So if our pH is going down and we're acidic, our CO2 is going to be going up, and vice versa. If our pH is high, our CO2 will be going down because it's respiratory opposite. Metabolic is going to move in the same direction, but it involves our pH and our bicarb. So if our pH is high and our bicarb is high, this is metabolic equal, and we know it's a metabolic problem. If our pH is low and our bicarb is low, we know it's moving in the same direction, i.e. it's equal, and it's a metabolic problem. Alrighty, and lastly, we're going to figure out, has the body already compensated for this, or are we still working? It's not quite compensated yet. Is it uncompensated? And the simplest way to do this is by seeing, well, is our pH still in a normal range? Because if it's back to a normal pH range between 7.35 and 7.45, the body has already kicked in to compensate, and we're back into a normal range. So this would be compensated. If we still have an abnormal pH range and we haven't been able to get that pH back into our 7.35 or 7.45 range, if it's still abnormal and lies outside of that range, we know it's uncompensated and our body hasn't been able to kick in, whether it's our kidneys or our lungs, to put us back into a normal range. This would be uncompensated. So again, first we figure out, is it acidosis or alkalosis? Second, we figure out, is it respiratory or metabolic? And third, we figure out, is it compensated or uncompensated? Alrighty, so keeping that in mind, let's go ahead and move on to our first of three questions. Alrighty, so it's simply, all that it's going to ask you is it gives you these charts. The good thing about the new NCLEX is that it gives you lab values already. It gives you normal reference ranges, so you don't have to memorize that. However, you do have to know how to interpret this to figure out whether it is respiratory acidosis, metabolic acidosis, any of those things in between. Alrighty, so we'll walk through this one together because I know these can be kind of tricky and intimidating. So again, our first question is asking you what state we are in. Alrighty, so our pH is 7.28. So what is that? Is that low or is that high? Well, remember, our normal pH is 7.35 to 7.45. 7.28 is below that, so we're in a state of acidosis. All right, part one done, check. All right, moving on. So now we need to figure out, well, is it respiratory or is it metabolic? So we know our Rome trick, respiratory opposite, metabolic equal. Our pH is going down, so you can draw a little down arrow by the pH. Now our CO2, that's 55. Is that high or low? So if it's 55, our CO2 normal range is 35 to 45. So we know 55 is running high, therefore it's going up. And our bicarb is 23, which is in between that 21 to 28 range. So our bicarb is normal. So here we would know, okay, our pH is going down, our carbon dioxide or CO2 is going up. Respiratory is opposite. This is opposite. So we know that it is respiratory. So our correct option would be option 3, which is respiratory acidosis. Great job, you guys. I see a lot of answer number 3. Way to go. I see a couple metabolic. This is tricky again, but remember that Rome trick is what's going to tell you whether it's metabolic or respiratory. All right, so I'm going to move on to question 2. I'm going to give you guys a little more time to do this one on your own. In the meantime, I'll drop a couple hints while we do it. But to note, we have an events page that has now gone live. It's a great reference. It's like a home base for all of our nursing social events and live events, and what it does is allows you to plug in your name and your email and get an email to your inbox at the beginning of every week that covers what topics we're going to cover in our lives and in our question drill, so you can see what's up on the docket for that week. It also shows you the next 3 weeks of our calendar, so you always know what time we're going live, what channels we're going to be live on, and what topics we're going to be covering. So especially if there's something that you struggle with, it's great to kind of keep an eye out and bookmark that, so when we do a live on it, you can join in and maybe get some needed clarification. Alrighty, so what are we thinking here? I see some Some 3s, I don't know if that's left over from the last answer, but I see a mix of 2s, 3s, and 4s. So we're a little bit all over the board, and that's totally okay. So let's walk through this one together now that you've had a chance to drop your answers in the chat. So our pH, is this high or is it low? Our normal pH range is going to be 7.35 to 7.45. Now this pH is 7.48, so this would be high, correct? So we're in a state of alkalosis because our pH is high. Alrighty, now let's look at our carbon dioxide and our bicarb. So our carbon dioxide is 30. Our normal range for carbon dioxide is going to be 35 to 45. So 30, we're running a little bit on the low side. And our bicarb is 24. Our normal range for that is 21 to 28. So we're smack in the middle. Bicarb doesn't have a problem. That's a normal range. So again, our pH is going up, but our carbon dioxide is going down. Now with our Rome trick, we know that respiratory is opposite. These are moving in opposite directions. Therefore, it would be a respiratory problem. And we already figured out that it's alkalosis. So this would be respiratory alkalosis, which was option number 4. So way to go, you guys. Great job. Alrighty, and I see a couple of answers in here. Alrighty, so I hope this makes sense to you. We're going to move on to question number 3, which this one challenges you a step further. It's challenging you to know whether or not it's compensated or uncompensated. So I'll give you guys some more time for this one, but then we're going to walk through it really, really fully to make sure everyone's on the same page before we head out for the day. But again, y'all have done so well today. Great job. This has been a long live, so thank you for bearing with me. Alrighty, on to question number 3. Drop those answers in the chats. This is our special bonus question for the day. We usually just do 2. While you guys are figuring out, and again, draw those arrows on your paper, on a sticky note, whatever you have near you. Those arrows really help drive home whether it's opposite or equal, so you can figure out whether or not it is metabolic or respiratory. But in the meantime, we have started to put out nurse life videos that cover all steps in the spectrum of the nursing journey. So they tell you more about an accelerated nursing program, if that's something you're into, what it's like to work holidays as a nurse in the hospital. Professor Brittany just put out one of those videos. So make sure you're tuned into all of our social channels. That way you can never miss a video and see everything that we're putting out. We have some exciting stuff in the docket. We have some stuff soon to come out about how to make a concept map, which I know I always struggled with as a nursing student. So I hope you guys are using these resources. I think they're so, so helpful, but make sure you're tuned into our social media channels so you don't miss any of them. Alrighty, so I'm going to check the chat, and the good news is that I feel like we are starting to get the hang of this because I see almost all correct answers, and that would be option 1, compensated metabolic acidosis. Okay, so let's walk through this. Why is this? Starting out with the simplest part, is it acidosis or alkalosis? Well, our pH here is 7.35 to 7.45. That's our normal range. But our pH is 7.37. So I know what you're thinking. How is this acidosis or alkalosis if it's a normal range? Well, the body, and this is a hint towards the answer, but could have already compensated, putting us back into a normal range. So even though this is a normal pH, it's still on the lower side. So for the sake of the question, I'm just going to put a down arrow because we're leaning more towards acidosis. Now looking at our CO2 and our bicarb, our CO2 is 33. This is slightly low. And our bicarb is 20. Again, slightly low. These are both going down. But if our pH is on the lower side and our CO2 is going on the lower side, they're both going down. So respiratory is opposite. That's not opposite. So we know it wouldn't be respiratory. Whereas our pH is going down and our bicarb is going down. Metabolic is equal. These are both going in the same direction. Therefore, this is a metabolic problem. So we know it's metabolic acidosis. We figured that out. However, our body has kicked in to compensate for this. And so in return, our pH is returned to that 7.35 to 7.45 normal range. And that's how we know that our body has compensated and we are indeed in a state of compensated metabolic acidosis, or option number 1. Alrighty, Great job, you guys. You did so well. A quick little key into what we're doing this week. Tomorrow we'll be back, myself and Nurse Jackie, for an infection question drill. And on Thursday, we're going to be back with Nurse Incoli and Professor Brittany for a developmental milestone question drill. So make sure you tune in for those. We also have a quick little slide to show you in case you're looking for more acid-base imbalance questions and you already have purchased UWorld. This is where you can go on our QBank to get more of these acid-base imbalance questions. If you're on a roll after today's lecture, go ahead and try your hand at a few more just to really drive it home. In closing, thank you so much for joining today. This was a lot to learn, but you all did so well. I'm sorry it went long. All of these lives are available on demand on our social channels. So if you missed anything, if you want to clarify something, tune back in on those so you don't have to miss anything. And join us again tomorrow at 2 and 3 p.m. Central Standard Time for infection question drills. Thank you so much, and I'll see you guys soon.